kind of announce that so you all know. So welcome to our series called Prepare for Victory Virtual Medical Symposium Series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on genetic aortic conditions from our professional advisory board and other leading medical experts on these conditions. We're grateful to the Chu and Chan Foundation for making these webinars possible. Before we get to our presentation tonight, we're going to have Michael Weimer, our President and CEO, welcome you all, and you will unmute now. Sorry for the echo.
Good evening, everyone. This is Mike Weimer. I just wanted to come by and first of all, thank you for joining us tonight. I hope you find these webinars as helpful and enjoyable as we have. We have a great physician leader tonight, Dr. Juan Bowen. You'll hear more about Juan, I'm sure, in a few minutes. But he's one of our really great physicians and also a great member of our PAB, our Professional Advisory Board, and really is extraordinary in helping the members of our community and their families. The other thing I'd like to mention, you know, I was sitting looking at tonight's topic, and I became involved in with the Marfan Foundation back in 1999 as a volunteer and then a member of the board and then as an advisor. But I was thinking back to 1999, and it was still all about the aorta for the most part. You know, we talked about other things, but usually came back to the aorta. And the other was, it was still about life expectancy. You know, everybody was still, you know, trying to figure out the life expectancy when you have Marfan or a related condition. And so roll that clock forward. And while the aorta certainly remains important from a Marfan and related conditions perspective, you know, now we're talking about quality of life, and we're talking about aging with Marfan and related conditions. So you can see what's happened over the last 20 years in the sense of the mission and the accomplishments from both a medical and also a research perspective. And when I get a chance to talk to younger community members, you know, I often suggest, what will the next 20 years bring? You know, let's look out, you know, 20 years from now, and what will it look like then? You know, and I'm as anxious as you are to find that out and to watch us, you know, continue to grow and change as an organization, and watch all the things that are most important to our community change for the good over the period of time. And I, quite honestly, I hope we have the same success in the next 20 years that we've enjoyed in the past 20. So with that, I'll turn it back over to Eileen. But I really appreciate you joining us, and I hope you have a tremendous evening. So thank you.
Thanks so much, Michael. Glad that you're able to join us tonight. We really appreciate that. So as you all know, tonight's presentation is on aging issues in Marfan and related conditions. And if you have questions during the presentation, please type them in the Q&A box, which you see on your screen. We will leave time at the end to answer the questions. You know, Dr. Bowen might actually answer those as you're going, you know, it might come up in the presentation. So you might want to wait till the end to put the questions in there, but we will answer them at the end. As Michael said, we are thrilled to have Dr. Juan Bowen, a member of our Professional Advisory Board, here to present tonight. Dr. Bowen is the director of the Marfan and Thoracic Aortic Clinic at Mayo Clinic in Rochester, Minnesota. He is board certified in internal medicine with additional advanced training in cardiology and also specialized training in geriatric medicine. So he's really perfect for this presentation. He's not only a medical expert, but he's also a true champion for our community. And I just encourage you guys to, if you have the opportunity to attend any of our events in Minnesota, a conference, you know, Dr. Bowen's one of those doctors that you do not want to miss out on connecting with. So now we're going to start the webinar. So I'm going to stop sharing my screen and give the remote control to let's see, remote control. Sorry, I have to do this first. I did the wrong order. Remote control, give the mouse to Juan Bowen. Great. So Dr. Bowen, can you get the, can you grab that mouse?
Okay, so now I'm going to hit share.
And pick your presentation.
Okay, there it is.
And yep, I see it.
Everybody can see it now?
Yep, I see it. We're good.
Good. Okay. All right. Well, yes, I'm excited to be here, and thank you very much for the invitation. And we're going to talk about aging a little bit in general, and then in aging with regard to Marfan syndrome and related conditions. Can everybody hear me okay? You can hear me all right? Okay. So
Yeah, I hear you. You're good.
okay, good. Now let me just see if I can advance my slides. Okay. I'm going to start off with a case. So this is one of our patients who's 59, and she's been known to have Marfan syndrome for a long time. When she was 53, she did have an operation and had the valve-sparing root repair done. So that took care of an immediate problem of the enlarging aorta. And this is an image of her aorta. So you can, hardly tell, but it's been repaired. And so that's out of the way. However, now at age 59, there's been a new problem where she's developed some unsteadiness in her gait. And she came and had a pretty comprehensive evaluation with imaging and neurology consultation and EMG test of muscles and nerves. And basically, several conditions were found. She has lumbar dural ectasia, which I'll show you an image, as many people with Marfan syndrome already have. She has degenerative arthritis in her hips, and she also had a peripheral neuropathy. It wasn't completely clear which of these were responsible for her problem, but probably all three were. And on the left panel here, you can see her image. This is a side view, and I think you can see my pointer. So these are the vertebral bodies, and this is the dural sac, which is continuous with the brain up there, but down here, it's full of cerebrospinal fluid. And this dark structure here is the spinal cord, and these are the spinal nerve roots. But her, in contrast, on the right side is a patient who does not have the Marfan syndrome. Again, you can see the same thing with the spinal cord as the black structure. But the patient on the right has a normal diameter dural sac, whereas our patient has an enlarged dural sac, and this is called dural ectasia. And it even intrudes a little bit into the bony spaces here. So this is not a normal thing to have. Many patients with Marfan syndrome have it, and it does contribute to low back pain and even disability. So as she faces the future, what health issues can she expect just simply, from aging? And also, are there specific problems that have to do with the Marfan syndrome? And I'll just tell you that even though we discovered these problems in her health several years ago when she was 59, now she's in her early 60s, and she's really done quite well. This has not been a progressive gait problem, and if anything, she's a little better now, which I've been very glad to see. Now, just talking about aging in general, I think most of you know that the population is aging, and this is a graph that the blue line would show roughly where we are now, and then the trends, of course, are that our people are aging, and we have many more older people. And especially over 85, as you can see with the red line. But it's important to recognize that a lot of them have many, several chronic conditions. I mean, 4 or 5 chronic conditions is from one study, but that's even a modest estimate. So they're burdened with chronic problems. And this is a slide that shows you just in the 1900, the purple line, what life expectancy was like at that time. And also now today, this is even a little old, it's 2003, but how much life expectancy we've gained as a population. So, we're all living longer now. And then in the Marfan syndrome in 1972, the median survival was age 48. That meant that half the patients were gone before the age of 48, and half of them survived beyond 48. And in 20 years, that had jumped up to 72 years. Now, why did that happen? And this little drawing here is a reminder for me to say a word about the fibrillin molecule. This is a 3-dimensional diagram of a molecule, and this is a very, very large molecule. This is fibrillin 1. But basically, in the last 30 years, a tremendous amount of basic and clinical research, by the way, a lot of it funded by the Marfan Foundation, has resulted in a very complete understanding of this molecule and its biology, and then other components of connective tissue as well. And this is a large molecule. There are around 2,000 fibrillin 1 mutations that have been identified already, and they can result, if you can imagine that a minor mutation would not alter the 3-dimensional structure that you're seeing very much, but a severe mutation would really cause this to look quite different, and it wouldn't function well at all in the body. So this is really a tribute to the basic and clinical research that has been done. And a huge reason for people surviving now is the Bentall operation, where the aorta can now be replaced successfully, and that's been the case for several decades. But going back to the general population, if you look at the causes of death, they're split between cardiovascular disease and cancer. So this is what is going to happen to most of us, about half or so cardiovascular problems and the other half cancer. And then a few other things that can happen, but those are the big ones. So that's what happens. Now, this is a really important thing to consider, that the health behaviors which we all have can reduce your life expectancy. So a huge one is tobacco use, as we all know, alcohol use, of course. And even, by the way, you don't have to be an alcoholic or have a serious dependency. Alcohol use that's considered socially appropriate can still be harmful to the body, and probably the safest amount of alcohol use would be a 0. And then the obesity epidemic, which we're familiar with. But these are 3 things that are behaviorally related, that if we could control these, health behavior, life expectancy would jump up in the United States. Now, with normal aging, there are many theories, and nobody knows exactly why we age or even how we age. There are many things that happen. But one thing that I see as a clinician is a decreased reserve. So if you're 30 years old, you've got a 10-fold reserve in all your organ systems. But over time, that reserve erodes away. And by the time you're in your 70s and 80s, you really have very little reserve. And then this produces some characteristic changes in the body systems that are just part of aging. Now, the Marfan and related disorders patient is going to have the same things that everybody has, but as well, some specific problems to them. And then, as Michael was saying, not only is there survival, but what about quality of life? So all of us want a reasonable mobility. It's nice if you can retain a vision and hearing and other special senses. We want to be free from severe pain. It's nice to have some level of energy to get through the day. And it's good to not be burdened by depression and anxiety. But these are all quality of life issues that are out there in the population, and especially so in our patient groups. Now, in 30 minutes, you can't go through everything, but I am going to say a few words about the important body systems and how they age in normal aging. So let's start with the cardiovascular system, because that's such a big one in the Marfan syndrome. This is my EPIC medical record program. So I'm going to see if I can instruct it to go away. Okay. Okay, so in the cardiovascular system, just normally, many of us have high blood pressure, which is wear and tear on the heart. I think it's 15% of us are going to wind up with some intervention on our heart valves during our lifetime. There's a very high risk of having a heart attack with a problem with the coronary arteries, and it's not sure exactly what the lifetime risk, but it's close to 50%, so it's extremely common. A few of us are going to wind up with conduction problems and a pacemaker. And then in some people, the heart muscle itself wears out, and this is a cardiomyopathy. So the cardiovascular system has characteristic ways that it ages. Now, if you take the cardiovascular system in our family of diseases, the aorta problems are well known, with the tendency towards aortic aneurysm formation. But Marfan patients particularly also have problems with the mitral valve, and frequently mitral leakage, and can require repair of the mitral valve in excess of what one would expect in the population. And then, as many of you know, the TGF-beta signaling pathway that's overactive in Marfan syndrome, when very high levels of this signaling molecule circulate in the body, they can have consequences for heart muscle. So Marfan patients can develop a cardiomyopathy. So there are some things to expect there. I mentioned the preventive aortic repair. This is the traditional repair that Hugh Bentall developed. This is a mechanical aortic valve. And the Marfan Foundation has funded a study now, which is more than 10 years old, of the valve sparing operation, where here's a native aortic valve in contrast to the mechanical valve. Same repair, but you get to keep your own valve and you don't have to go on anticoagulation. So these are nice therapies that are available now. Now the kidneys are critical because the ability of the body to handle volume and salt and potassium is just essential for life. And all of us begin to decline in our kidney function and lose a little bit of filtering action in the kidneys. But hypertension accelerates this, so does diabetes. And very importantly, some of the medications, particularly the non-steroidal anti-inflammatories like ibuprofen, as one ages, these are toxic to the kidneys, and other medications can be toxic. So the kidneys are really critical for health. And when one loses kidney function, there's a lot of loss of good health. Now, in the Marfan syndrome and related diseases, there are some very benign changes, but on imaging, simple cysts, which are harmless, occur in higher numbers than in the general population. And then people with Marfan syndrome don't have a specific form of kidney disease, but they are vulnerable to the kidney diseases that everybody else has. And because they have more vascular problems than the general population, the kidneys can be damaged because of vascular problems and impaired blood flow. This is an example on the left panel of, this is a water-filled simple benign cyst in the right kidney. This is the left kidney. And so this is a situation that occurs more commonly in Marfan syndrome. And as impressive as that looks, it's almost always harmless. It doesn't affect kidney function. On the right, this is a patient who's had an aortic dissection. And because of this, there has been impaired blood flow to the left kidney. So the healthy looking right kidney is over here, but the left kidney has a little piece that's missing, and that's from obstruction of blood flow and impairment of blood flow. Now the eye is critical in all of us, and we can all get cataracts, we can all get glaucoma. Macular degeneration is common in the general population. The Marfan patient tends to have severe myopia, and the eye in severe myopia has a flatter shape and is very susceptible to retinal tears. So that can definitely happen, and they can be serious, more risk in the Marfan syndrome than in the general population. Many patients with Marfan syndrome have dislocation of the ocular lenses from connective tissue weakness, and then that is going to introduce other problems that can lead to glaucoma. And so this is just it's very clear from looking at this that the Marfan patient needs very good eye care and lifelong eye care. This would be an example of a dislocated lens where you can, if you could see here, you would see disrupted little cables that hold the lens in place, but they've been disrupted because of tissue weakness. And then I like this slide because this is what we look for when we examine the patient, this quivery movement of the eye. And the other thing I like about it is it has a great name. This is called iridodenesis. And we look for iridodenesis because it tells us that the lens is probably dislocated in that person. And it's a very specific finding that usually indicates Marfan syndrome. Now, in the general population, the spine and the joints, of course, age, and it's common to have spinal degenerative arthritis. I'm not talking about the rheumatoid or degenerative or inflammatory arthritis, but I'm talking about just the wear and tear. But this affects the hips and knees. Many people have joint replacements. And then there's a problem of people beginning to lose muscle mass even as early as the age of 50. And this is quite variable. Some people lose a lot more than others, but this is a problem with aging. Now, if you have the Marfan syndrome or one of the related disorders, you have additional challenges because there's a good chance you have scoliosis, and you may have overgrowth of the ribs pushing in the sternum and producing the pectus problems, and the dural ectasia, which I showed you before. So the spine is a problem, and the chest wall changes affect the function of the lungs. So this introduces not just dysfunction, but even pulmonary impairment and even neurological problems. In some of the syndromes, one of the Loeys-Dietz family of defects is in the SMAD3 protein, and they get a really bad early degenerative arthritis. And then all patients with these families, in this family of diseases, can have acceleration of muscle problems and even what's known as a myopathy or a disease of skeletal muscle. And this is probably because of the high TGF-beta signaling. Now, these are just x-rays showing the impressive curvature of the spine and the Marfan syndrome and how it can be addressed with spinal operations and straightening. Takes a lot of hardware. This again is the dural ectasia. Now, this is a patient, this is a CAT scan and a lateral view. It's not an MRI, but you can see here that the same sort of enlargement and scalloping of the dural sac. And in contrast, here's a normal patient where none of that is happening. So this is a problem because the nerve roots travel through here and can be affected by this problem. Now, fortunately, it tends to be pretty stable and usually doesn't require intervention. And this is another view, a cross-sectional view. Again, on the right, this is the way the spinal canal is supposed to look, this little triangle. But in our patient, in the left-hand panel, this is now, you can see where this is even eating into the bone. So this is an impressive looking problem on X-ray, dural ectasia. Now, the respiratory system ages in all of us, even though the Marfan patient will have a worse lung function because of the impairment of lung mechanics. Even in normal aging, lung mechanics are not normal. The chest wall doesn't function quite as well, and your lungs expand passively, so they completely dependent on the neuromuscular and anatomical structure of the chest wall. Asthma and emphysema are common in the general population. There are not really great studies in the Marfan syndrome of the exact risk of these problems, but we talked about the chest wall and its effects on lung function. Asthma and emphysema, probably a little more common, although we're lacking in good studies to really prove that. The same thing with sleep apnea. All of us have the impression that sleep apnea is more common in Marfan syndrome. And it is more common in small studies, but really big studies with big registries haven't been done. But all of us have the impression that this is a bigger problem in the Marfan syndrome than in the general population. Pneumothorax, of course, if the connective tissue that lines the lung is weak and the little blisters pop, then you have a collapsed lung and a pneumothorax. So this is just an example on the left side of a Marfan patient with, you can see how the lungs would be impaired with their function. This is the sternum, which is deformed. The chest wall is really caved in, even to the extent of compressing the heart and affecting the lung volumes. And this is the way the chest wall is supposed to look on the right side, nice oval shape, and without the mechanical disadvantage that you see on the left. This is an image of a report from an oxygen saturation monitor. So this patient wore one during sleep, and you can see up here, this is the pulse, and we'll ignore this at the bottom, but at the black at the top, everyone should have a normal oxygen saturation or in the 95% range, and that should be an even flat line all the way across. But this patient periodically has desaturations from obstructive events during the night. So here's one, here's another cluster, here's another cluster. And this can be relatively mild as this is, or it can be very severe with much of the night spent with very low oxygen levels. And the patient, of course, is asleep and is not aware that this is happening. This would be an image of the pneumothorax we talked about. As terrible as this looks, people rarely die of this. The lung often inflates itself or may need some help, but most of the time this is not going to have dire consequences. Now, all of us care about the way our nervous system functions, and right around the age of 75 or 80, normal people begin to notice that they're not quite as sharp with their sense of balance. About 1% of us will get Parkinson's disease. I don't know the exact lifetime risk of having a peripheral neuropathy, but they're common, and people notice that their peripheral nerves are not as sharp as they were when they were young, particularly with diabetes. And then, concerning to all of us is what happens to our cognitive function. So there have been studies done on normal aging and cognitive function, and there is some decline just in normal aging. So people can't pay attention quite as well. They process more slowly. They have an episodic memory refers to a specific type of memory where you're remembering things along with the context. So it's a kind of a complex memory function that does decline even in normal people. Now, I should say that this is extremely variable, and some people have very little decline and others have more, and these are normal people. Now, it has been shown that those who have a lifelong pattern of an active and engaged lifestyle do better. And so that includes physical activity, includes mental activity and social activity. So the engaged and involved person does better. And then as we age, those who maintain high levels of physical activity tend to preserve their cognitive function better than those who don't. And this is just, there are many types of new imaging, and I just picked one, but this is a scan that is now available here in our institution. And this arrow points to the hippocampus. This is a patient with Alzheimer's disease, and you can see that there's a lot of atrophy in the brain in general compared to the healthy normal person in the right side. But in particular, the hippocampus is atrophic, and if you look over here on the right, that's a nice and plump normal hippocampus, and the rest of the brain also does not have this atrophy that is seen in the Alzheimer patient on the left. Now, what happens if you have the Marfan syndrome or a related disorder? Well, to my knowledge anyway, from my reading of the literature, nothing has been demonstrated that's adverse. So probably about the same risk as the general population. However, it is true though that the Marfan and related disorders patients do have more effects in the peripheral nervous system, and probably because of the dural ectasia and the structural changes in the spine. So this would include impairment of sensory nerve function with decreased sensation, even some weakness in nerve roots. So, this would be, I think, a challenge that is more in the Marfan syndrome and related disorders. Now, the endocrine system is critical because I think it's 1 in 7 Americans will develop type 2 diabetes. Thyroid disease affects 15% of normal women, and the risk for men is about half of that. Osteoporosis, of course, is extremely common in women as they age, but also I think it's around 15% of men, so it's a challenge for both. What if you have the Marfan syndrome or a related disorder? Well, generally Marfan patients are very thin when they're young, but as they get into middle age, they do seem to acquire a central obesity, many of them do, with an increased risk of diabetes. Now, this has not been demonstrated by rigorous large-scale studies, but again, it's an impression I think that most of us have. And this is a challenge, and we don't quite know why this central obesity occurs. The same way, the large registry type studies have not been done to prove that the Marfan patient has more osteoporosis, but those of us who care for Marfan patients think they probably do. They probably don't achieve peak bone density when they're young. So when bone density declines as expected with age, there's a problem there. And then this would be just an illustration of these variations in fat distribution. The panel on the right would be the apple. And this is the person with a lot of intra-abdominal fat inside the abdominal cavity. And this is harmful fat that leads to metabolic consequences, elevated triglyceride levels, elevated blood sugar levels. And the person with the more pear shape has less risk of these metabolic adverse results. And this is, again, just an illustration of how the bone density reports read. They have a technique using photons to measure the bone density in the very specific places where they put their little box exactly where they want to measure it, and then we get a printout. So there are good techniques for this. Moving on to the GI system, a lot of us have acid reflux and take antacids. Constipation particularly is a problem as people age. The nervous system is extremely complicated in the gastrointestinal tract. It's almost like another brain that regulates the motility and the peristalsis in the gastrointestinal system. And this hasn't been adequately studied in our family of diseases, but many patients with Marfan syndrome do have, I think, more acid reflux, and there's more a hiatal hernia problem where part of the stomach herniates into the chest cavity, and the central obesity doesn't help this. And because the nervous system, the autonomic nervous system is so critical for impairments, for function of the motility of the bowel, it's unclear, hasn't been proven, but again, I certainly see this in Marfan patients, and it again may be related to their spine as well. So more constipation problems in general, I think somewhat more gastrointestinal problems. Now, although those haven't been proven, this is a condition called eosinophilic esophagitis, and the esophagus should be a smooth tube, and here it has sort of a ringed appearance on an endoscopic photograph. And then these little cells with the arrows are called eosinophils, and these are cells that are found in allergy. And in the Loeys-Dietz syndrome, this particular condition, this is eosinophilic esophagitis. It's a form of allergic esophageal inflammation that occurs very commonly in the Loeys-Dietz syndrome. And it's probably because Loeys-Dietz patients have very, very high TGF-beta signaling, and the TGF-beta system participates in the development of the immune system. So there's probably something that went wrong in very early development in this body with the immune system that stimulated this type of allergic type of inflammation. And these patients tend to have food allergies. So critical problem in the body is, how does our blood system age? We're unaware of it, but our bone marrow is cranking out gazillions of red cells, white cells, and platelets every day, and we just depend on that working normally. And if one cell line is altered, for example, if anemia develops or low platelets, it's usually not a serious bone marrow disease, but it's something else in the person's health. But when all three of them begin to malfunction, that's usually a bone marrow problem. And many of us will get bone marrow malignancies, B-cell lymphomas, Hodgkin's disease, chronic lymphocytic leukemia. These are common malignant disorders. Now, what about our family of patients? They don't seem to have excessive malignancies in the bone marrow. They do have the eosinophilic disorders in the Loeys-Dietz syndrome, as I mentioned. And to my knowledge, this is the only real consequence in the blood system that I know about. But we encounter this in interesting ways. This is a Marfan patient who was going to have an aortic repair and just had the regular imaging. But the radiologist noticed a finding here and thought, well, that looks like an enlarged lymph node. And so this is a PET scan where there's a material injected that shows the very metabolically active parts of the body. And here, for example, this is just the bladder collecting the radiation. But here is an extremely overactive area metabolically, and that corresponds to what was seen in the other slide. That's a malignant lymph node. So this patient had a lymphoma, so we had to put the aortic repair on pause. She had successful chemotherapy for lymphoma. The lymphoma went away. Then she had her aortic repair. But that would be an example of, finding these unexpectedly because you're not dealing with older patients. Now, I have to discuss mental health problems, extremely common in the general population. High rates of depression and anxiety. Chronic pain is a challenge in the general population. And in the United Kingdom, there's even, I think, a new cabinet level position to deal with what are we going to do about the problem of loneliness in our aging population. So these are worldwide problems in the normal population. Now this is yielding to some extent to science. Chronic pain is an example where now I'm not really skilled enough or competent enough to tell you the great detail about this, but this is a functional MRI scan, and the areas that are lighting up are the pain centers. So there are people with chronic pain who have, this isn't something they're imagining. Their pain centers in the brain are actually active and firing when the normal persons would not be. So even when they're not facing a pain stimulus, they have so-called central pain. So this is we're beginning to have some tools now for understanding this and hopefully treating it better. What happens in our mental health situation with our patient group? Well, much of this comes from surveys of patients, and they do report higher rates of depression and anxiety than the general population, much more chronic pain than the general population, high rates of disability. So this is what we're hearing from our patients. They appreciate what we've done as far as their aortas and getting timely surgery, but then they still have these issues to deal with as lifelong problems. And how do you deal with it? Well, a lot of the problems we solve ourselves, and we should. And so we have to have self-care skills. We should have good primary care where there's a primary care home that's going to take care of health maintenance, immunizations, cancer screening, respond to symptoms and help us sort them out. But as they get sorted out, sometimes we do need good specialty care. And this is a challenge, and it's a challenge everywhere. Certainly here in Minnesota, where I live in Rochester, we're fortunate to have the Mayo Clinic, but not every place has the Mayo Clinic in their backyard. And even here, there are problems with the coordination of all this. I can't leave these topics without saying a word about the wonderful document that Dr. Braverman wrote that's on the Marfan website. And this is in the self-care area about how do we take care of ourselves and remain active in a safe way? So there's a nice document that we should read, kind of instructing us about different kinds of exercise and what self levels are. I'm showing this slide simply because all of us are going to be having this challenge of, several or even many medications, and then how does the body handle this with age? Kidney function, liver function is not the same with age. One drug interferes with another, or this is a drug-disease interaction. For example, maybe your heart condition is compensated, but the doctor gives you a diuretic, and now you have to go to the bathroom more often, but your prostate is a problem, so you now have a drug-disease interaction where you develop incontinence. You wouldn't have had incontinence if your prostate was healthy. So you begin to get into all these complications. And then this is a huge topic. We can't discuss it in general, but there are sort of unregulated items out there that are promoted and people take them. Most of them are safe, but they're not all safe. So be cautious about adding things that haven't gone through FDA scrutiny. And in the end, somebody like me has all this literature and publications, and you see them as well. And how do we make sense of this? Well, we make sense of it by special groups of, organizations appoint panels of people to review and grade evidence. They then write practice guidelines for us. But the practice guidelines are not, can't be followed without using clinical judgment. So hopefully we're going to use a clinical judgment as we interpret them and apply them to our patient. And then you can't do this in a vacuum where the patient is a part of the decision making. So you do this together, and this would be a good way of making decisions in medical care. So I'll close just by saying that not just in the Marfan syndrome, but in general, all of us need all of these components at some point during our lives of good health care. But if you have the Marfan syndrome and you age, then there are special concerns and related disorders. You may change in your function relative to the general population. You have special challenges in quality of life. You may live in a rural area and have some trouble with access of resources. Hold on just one second. Yeah. No, you go ahead, yeah. Okay, so and then really sort of getting towards the end of life, we all need good palliative care, and we live in a social environment which hopefully will be there for the rest of our lives, and there's a spiritual component to our health. So now with that, I want to leave plenty of time for questions. I'll just show our little banner of the Marfan syndrome, and this is a summary where we now have better research, and medical practice is better than ever. We do have challenges with our leading causes of death. We have now major gains in life expectancy in our family of diseases, but we do need to continue with our regular primary care and specialty care, of course. And hopefully, if I give this talk in 5 or 10 years, I'll have a lot more information as better research, again, continues to help us with the conditions of Marfan syndrome and related disorders and aging. So with that, this is my email, and I welcome any questions from any of you. But I hopefully left enough time that we can have maybe 20 or 25 minutes to interact.
Great. Thank you so much for that, Dr. Bowen. That was really great. I'm going to go back to my slides here. Can you guys, we go back to mine over here. And before we go on, I mean, first of all, that was a great presentation, and you really left a great opening for me to talk about backpack health for a minute. Backpack health, hopefully everybody who's logged in knows about this. It's a partnership that the Marfan Foundation has with Backpack Health, which is an app, a smartphone app that does two things. It helps you compile all your health information in one place securely, easily, in several languages, and helps you share it securely. Also, whether it's for emergency purposes or whether you're traveling or your family members traveling. But the other thing that's really important, which kind of building off of what Dr. Bowen said, he's talking about research on Marfan, especially in with this whole aging situation. And aging is a great thing for this community, but there are a lot of questions that are unanswered because previous generations weren't aging like this. And so with Backpack Health, once you are in Backpack Health and using it, you can then join our registry. It's the first international patient registry on Marfan and related conditions. And when you join that and you consent to do that, your information is de-identified, so nobody knows it's yours, and it's aggregated, which means combined with everybody else's. And then in the future, researchers will be able to collect data from a big group of people with Marfan and related conditions and study these aging questions. And so hopefully, you know, in 20 years, 30 years, we will have more answers than we have questions right now. So I really encourage you to join Backpack Health. When I do the follow-up email to all of you, I will send the link so you can get that too. It's free and it's easy. So I needed to put my plug in for that. So now we're gonna go to questions. So I think I don't know if you guys put some in the question and answer box. I see some in the things in the chat. So I think you guys were talking about acid reflux. Let me see if there's any questions in here. All right, there's a couple questions in here, so we'll go to those, but then anything else, please put in the Q&A box. So Dr. Bowen, one question is, what about lifestyle choices for somebody's son who is 14, choices that they make now that can help him age as best as he can with Marfan? That's a great question.
Yes, this is a great question. Well, yeah, and really this gets to the issue of balance. So I remember when I was 14, I was a little unbalanced. And if I wanted to do things, I just did them. And for the vast majority of 14-year-olds, you know, the body allows that and everything's fine. But if you've affected in a significant way and you have got aortic problems, then I think it's possible when children can still be under somewhat of an influence by their parents, you know, to steer them into things that are not going to be too dangerous. Instead of playing on the football team, maybe you know, something else that's less demanding on the body can be done, and music, something that's some lifelong activity, or if it's a sport that isn't quite as tough on the body, golf or something. So I think there's some modification and some acceptance has to be made, but there was a study that was done on Marfan syndrome mice a couple of years ago, and without going into all the details of it, there were three little groups of mice: the very sedentary mice, the medium active mice, and then the overactive mice that they stressed by exercising them on a little mouse treadmill too much. And basically the group with the healthy aortas were the medium active mice. So I think appropriate, moderate levels of physical activity are necessary for all of us for physical and mental health, and also for this 14-year-old.
Great. All right, thank you. Yeah, that's good advice. Just going on to another question about exercise. I mean, somebody else is a little bit older, 50, on disability, has physical and mental issues, chronic pain, joint issues. When it's hard to walk and it's painful to even walk, how do you safely remain active?
Well, I think a good place to start is to meet with a physical therapist or a trainer, and you might not find the right one the first time. Even here, with all the wealth of specialties and everything that we have, the patients will say, well, I went to see that physical therapist, but they really didn't answer my question. Okay, then let's find another one. And sometimes it doesn't even have to be a physical therapist. In our gym, we have all these trainers with master's degrees. So somebody who is, and they don't even have to know the disease that well. I think one of the qualities that you need in people who helping you is somebody who's interested and somebody who's willing to learn about you and what you can do, and to follow you and see you more than once. So I have patients who have developed, maybe they can't jog anymore, but they can water walk. Somebody shows them how to adjust the seat on the bicycle so it doesn't stress your knees. I had knee problems some years ago, and they showed me, look, set your seat like this and pedal this way and won't stress your knees, etc. So something can be done for most people, but it does require a little help.
Right, and like you said, asking and continuing to ask till you get an answer that works for you is great. Mm-hmm. Here, this is an interesting question. Somebody just posted, he's having aortic repair and corrective chest surgery. in August at Cleveland Clinic. He's nervous about it. He's only turning 35, so he already feels like he's falling apart. So, you know, people feel that way a lot earlier in Marfan than when, you know, in the general population. So when things seem to be going poorly, like what's your advice for them and to get through this kind of surgery and have hope for the future?
Well, I think that you know, if you take a step back and you look at how we should practice, it should be in a biopsychosocial context. So there's, you know, the bio, there's the psycho, and there's the social, and they all intersect. And I think one of the things that is just natural is that when you're having a problem and then another problem, it can seem like these are cascading and, you know, you're not going to get better. But in fact, most of the time, these problems will be addressed and relieved to some extent, maybe not completely eliminated, but, and then you'll return to a reasonable baseline. And then I think some of us, and including me, have a human tendency to project and sort of catastrophize our thinking, and we will run scripts in our brain that might be wrong. They might, and this is what cognitive behavioral therapy addresses. So I think we have a tendency in the United States and probably most of the world to address physical problems and then mental problems when they're really bad. Then you go to the psychiatrist. But wouldn't it be nice if we had a way of addressing together the physical problems and the psychosocial problems, because they're going to develop concurrently. And so I think all of us need to keep that in mind when we're facing these challenges, because things may just come back to a very reasonable place and you may go 10 years before you have other major problems, or longer. I have many patients. I have a patient with, this patient has vascular Ehlers-Danlos syndrome who was in an ICU 30 years ago with terrible crisis. And the crisis passed eventually and then done fine for 30 years.
Wow. Wow. I just wanted to add a couple of things to that. I mean, I've been learning a lot about anxiety, the mental health part of dealing with having a chronic condition, the complex condition that, you know, progresses over the years. Two things I wanted to share. One is to learn some coping mechanisms and how to deal with the anxiety before you get to that catastrophe. Because it's like if you practice all the time, then when you get to that part where something, you have one of these big challenges in front of you, you've already practiced dealing with, you know, dealing with things. And so it's, even if you don't have something major coming up, you know, start learning about, you know, mindfulness and coping mechanisms so that when something big is happening, you've already practiced it. So I've learned that from our social workers. I also wanted to throw out, and I'll send you guys a link to this, is we are having a quality of life webinar on dealing with anxiety and depression in a few weeks. And so you'll be able to hear from an expert specifically on that topic. So I'll send out a link for that so you all can get that directly into your email tomorrow. Okay, next question. Okay, neuropathy. I know you mentioned it. Is it more common in Marfan, or is it one of those things that is common in the general population and so people with Marfan get it also, or do you see more of it?
Well, I was able to find one study, but it was very small numbers of patients, and it's very hard to generalize from it. So it's a largely unstudied problem. A little bit getting back to your backpack points, that when we have, you know, large registries with many, you know, patients participating, then we'll be more confident in what we say. But I think it probably is more common, but it's a heterogeneous group of disorders, and most of the neuropathies are not going to be terribly disabling. There will be some impairment in sensory function and in motor function, but they need to be evaluated, because in some of them, I've had several patients where it was a B12 deficiency, and with you know, B12 supplementation, things got much better. So a medical evaluation is always appropriate. And the very mild neuropathies don't necessarily have to go to the neurologist. A good general doctor who knows what to evaluate, like thyroid and like B12, can evaluate them. But the ones that really do need the neurologist are the more severe ones. If they're progressing rapidly or asymmetric or have a significant motor component where there's weakness, because I had a patient like that who developed a severe neuropathy, and it turned out to be from multiple myeloma, from a bone marrow malignancy. So it's a big topic, but thankfully most of the time it's not going to be a terribly disabling problem.
Okay, good. So here's a medication question. So people with Marfan are on either beta blocker or losartan. This particular person said he's on a higher dose of losartan. What about the long-term use of these medications in somebody with Marfan? They're, they're taking them for decades.
Well, that's right. And now, fortunately, the track record of these medications is good. And there are some problems that are well known. The beta blockers people can feel lethargic, or they can produce a slow heart rate. The calcium channel blockers, or the angiotensin receptor blockers, much less so, better tolerated. There's a long track record of these drugs because of their usefulness in diabetes and in other things. So I don't think we should be giving these drugs to people who are completely well and don't have anything wrong with them. But when you're giving them for a good reason, then I think the benefit far outweighs the risk.
All right, great. Here's a great question. For back pain, would you talk about which doctor you go to, the orthopedist, neurologist, is there another doctor? This particular person says for his situation or her situation, the orthopedist wasn't very helpful. What are the advantages to going to a neurologist? Where do you go?
This is a great question. Well, so this is there are different reasons for having back pain, and there are different solutions, and also different communities and different institutions organize the care a little differently. So, for example, what we have here is, first of all, they see a general person who can usually tell. There is a kind of what they call, it's called myofascial, a kind of a broad, hard to localize pain that's common, that doesn't really get better with spine injections because there's no sort of pain generator that you can identify. But sometimes you can identify a specific pain generator, like a lumbar facet joint. Those are good candidates for a spine injection localized right into that facet joint, which is available now in many communities. So there are some mechanical things that here at Mayo we have trained radiologists who know how to do that. We also have anesthesia pain experts, but it might be a different person where you live. So figuring out who benefits from an intervention, and then everybody benefits from core strengthening and just good maintenance and care of the spine. But also pain waxes and wanes, and for unknown reasons. So there can be a situation where you've now had pain for some time and it just feels like you're always going to have it. And then for whatever reason, it just gets better. So that's also something nice to keep in mind, that for a lot of these problems, they're not necessarily going to be there forever or get steadily worse. They frequently get better.
We also, I should put a plug in for this, we actually had a webinar on pain management with Dr. Tracy Speed from Johns Hopkins. So people can log onto our website and get that recording and get some more information on that. Yeah, here's a great question. As you get older, how do you distinguish between what is Marfan and what is getting older? And how do you help guide your physicians through this maze? I mean, you want to, I guess people want black and white. It might not be so black and white. No,
that's right. I mean, there's still a lot of room for I think your best bet there is just to find a doctor who's a good clinician and who's sympathetic and interested in you and is curious and open-minded, because as you said earlier, this is a new experience for all of us. I'm for the first time dealing with Marfan patients who are in their 70s that wasn't there before. So may not have all the answers. Yeah.
Well, we need to tie up some loose ends right now as we're getting close to the top of the hour. And I see there are more questions, and I am going to take all these questions. We have a nurse in our health center, Jan Lynch, who will either answer them on her own, or she will get in touch with Dr. Bowen to answer these questions too. But a lot of these, I think we can answer. There's a lot of good questions here that we have information on. So let me just tie up some loose ends here. So first, I want to thank Dr. Bowen for his time tonight, and thank all of you for joining us. We are going to not only get your questions answered, I will send you some of the links of the things that Dr. Bowen talked about tonight: backpack health, the physical physical activity guidelines and some of the other points that he made. And we'll also send out a link to the recording in case you want to check back on some things, and obviously for people who did not get to see it, who had registered. So this summer, we're going to take a little break on the webinars, and we're going to welcome you all to our 35th annual conference. Wait, I am getting ahead of myself here. Anyway, so the past recordings of the webinars are on our website. So if you go to Patients and Families, you see on the left the Virtual Medical Symposium. Those are our medical webinars, and right under it, Empowerment Series. Those are the Quality of Life webinars. So you can certainly access the recordings on all of those. Now, this summer we're taking a hiatus from the webinars, and while everybody's enjoying the outdoors in the evening, but we are going to focus on our 35th annual conference, which is in Houston from July 11th to 14th. You'll want to register before June 15th to get the early registration discount. Also, that's the deadline for the children, teen, and young adult programming, and also the deadline for our reduced conference hotel rates. So June 15th is definitely want to register by then. We'll have Dr. Bowen, all the other medical experts on our professional advisory board will be there. It's really an unbelievable opportunity. And you'll meet hundreds of people from our community. It's really amazing. Other opportunities for you to meet not only our doctors, but also community. If you see our Walks for Victory are going strong, Dr. Bowen, hopefully you'll be at the one in Minnesota. I don't know if your schedule allows.
I'll be there.
But he will be there. So you can meet up with him there. And then we're in all parts of the country for that. We have 2 regional symposiums going on in June. We have Camp Victory for Kids, which is just for kids with Marfan and related conditions. All that information is at marfan.org. And again, as I mentioned, there's Jan Lynch, our amazing nurse who heads our Help and Resource Center. And there's her contact information, or you can go to Ask a Question page at marfan.org, and she is always available to answer your questions. So thank you again for joining us. I promise I will get the rest of these questions answered for you. And thank you, Dr. Bowen. We really
thank you very much
tonight. And everybody have a good night, and I hope to see you all soon. Take care.
Eileen.
I'm going to end this, so
Okay,
I will call you separately.
Okay.
Okay, I'll call you back. Bye.
Okay.